Right now there's blood outside of the lung can't expand, so you're going to have air hunger, difficulty breathing, you're going to be in shock, because basically for two ways, the lung can't expand, and it's actually getting compressed, the vena cava is getting compressed, and you have blood loss. Right? And so that explains the flat versus distending neck veins. You can have either of the two. It depends on the patient. Because remember, we're having a compression of the vena cava, so you should expect distended neck veins, but why would they be flat? Because now the guy's missing a lot of his blood volume. And then shock with no breath sounds or progression to dullness. Again, sort of an academic definition, trying to differentiate tympany to percussion versus dullness to percussion. It's hard to do in the ER. It's impossible to do in the back of an ambulance. I mean, I'm sorry. It's just, if you can do that, then you're incredible. All right. Massive hemothorax, so rapid volume restoration. Fluid, blood products, chest decompression and X-ray, autotransfusion, operative intervention. What's autotransfusion?
Catching the blood in a thermosil and giving it back to the patient.
Everyone get that? Makes a lot of sense, right? You get 1,500 cc's of blood in a chest tube into the hemovac. Okay, what do you do with that blood? It would make a lot of sense to give that blood back to the patient. Or you can drink it, but you can give that blood back to the patient. You're pretty sure that it's the same blood type, right? So it makes a lot of sense. And some forward-thinking places have the facilities to do that. Or you can drink it. Cardiac tamponade. What happened to this guy? He got up to change the channel and trips, and now he gets better reception. So, cardiac tamponade. What's going on with the cardiac tamponade? So there's another sac, right? This is a sac that envelops your heart, and this is it's a fibrous, pretty tough sac, and that sac has a very thin amount of mucus, all right, but not very much room. And so if you have any bleeding into that potential space, you can basically have tamponade, right, a constriction of your heart. And so now your heart's not able to expand and pump out the blood to the rest of your body. So you have decreased blood pressure, distended neck veins, okay, muffled heart sounds, and PEA. You guys remember the H's and T's for PEA? It's one of them, right? This is the T. This is one of the T's. Tamponade. And so is tension pneumothorax. So for cardiac tamponade, secure the airway, ventilate and oxygenate, volume resuscitation, and the patient needs some type of drainage of their pericardium. Right? They need to drain that fluid around the blood around the pericardium, either with a needle, initially a needle, or just a plain old window. And this fast is actually sort of a double entendre. It could mean getting to the OR fast, or getting to the hospital quickly, or focused abdominal sonography and trauma. Basically taking an ultrasound and taking a quick look at the pericardial space and seeing if there's a fluid around it. So resuscitative thoracotomy. When should I consider resuscitative thoracotomy? So our initial scenario, 27-year-old guy, he was in a car accident, blunt trauma, he's unrestrained, he has some bruising on his chest. By the time you get to him, he's talking to you, but he's really pretty somnolent, he's babbling and moaning. He has vital signs. By the time you're rolling through the door, he loses his vital signs. Should this guy have his chest opened up? And what are we doing when we're opening up someone's chest? There's a couple things you can do. You can open up someone's chest and relieve their pericardial tamponade, right? You can nick their pericardium and try to relieve the tamponade. You could, if there's a laceration on the ventricle, you could try to stable it, and then you can try to cross-clamp the aorta. Okay? So there's really not much you can do, but in a blunt trauma, Guy has vital signs at the scene, he gets to the hospital, as he's rolling through the door, he loses his vital signs. Should they open up his chest? Who would do it? Why? What are his odds of survival without a thoracotomy?
0.
0. What are his odds of survival with a thoracotomy?
10.
0. 0 or near 0. Okay. How about this guy? Let's see. This guy goes to change the channel. Now comes in, has vital signs at the scene. Similar 27-year-old guy, vital signs at the scene. As you guys are wheeling him in, he goes down. Okay. No vitals. Should he have his chest opened up? Probably. Yeah. And what's the difference?
With trauma on here.
Penetrating. Okay. So blunt trauma, blunt thoracic trauma, with vital signs at the scene and then loss of vital signs once they're en route, you can't get them back. You just can't get them back. Penetrating trauma, there's at least a chance. There's a very small chance, but there's at least a chance that you'll be able to get them back. So that's the whole thought process for that. So it's penetrating trauma with vital signs at the scene. If you can get them to the ED and they lose their vital signs at some point, then at least they can consider resuscitative thoracotomy. Blunt trauma, don't expose everyone to the risk of a laceration from a broken rib. When we open someone's chest, there's a lot of scalpels, a lot of blades flying around, and the edges of broken ribs are incredibly sharp. And if the patient is not going to get back with a blunt trauma, there's no need to expose everyone to that kind of healthcare exposure. So, what are the potentially life-threatening chest injuries? How do I identify them? And when and how do I correct the problem? So we talked about the couple, tension pneumothorax, massive hemothorax, tamponade, even a laryngotracheal disruption. So these are some of the other injuries that you'll probably wind up picking up on secondary survey or with imaging. Tracheobronchial tree injury, simple pneumothorax, a pulmonary contusion, and a submassive hemothorax. In addition, cardiac contusion, a traumatic aortic disruption, blunt esophageal rupture, traumatic diaphragmatic injury. These two are pretty much fatal, except in rare instances. But these two are pretty bad. The problem is we won't be able to pick these up on the scene, and usually, except for an extensive workup, they're tougher to pick up. So how do I identify these potentially life-threatening thoracic injuries? Well, what do we have on our rigs? We have physical exam, and we have EKG and pulse ox. We don't have chest x-rays or ABGs or CAT scanners or MRIs yet. Soon. So tracheobronchial tree injury. It's often missed. They usually need a bronchoscopy, and oftentimes you can see, what's one of the findings you might see with tracheobronchial tree injury? So they might have a pneumothorax, and when you put in a chest tube, you have a persistent air leak, right? Because the air is still leaking out of the injured bronchial. But what would you see on physical exam finding at times? Yeah, sub-Q air, right? So they sort of feel like that. What's it usually described as? Like the snap, crackle, pop of Rice Krispies. So these patients need